My name is Sam Dobson. I'm a consultant gynecologist, but I also subspecialise in reproductive medicine, which includes things like menopause and fertility, amongst other things. And I've also done my specialist accreditation for menopause with the British Menopause Society, and also I'm a trainer. So I work at the Park Hospital in Nottingham and also Thornbury Hospital based in Sheffield. Okay, so tried to sort of condense it down into what I think is important to kind of understand about menopause and the treatments, talk a bit about the symptoms that you might experience, and talk about the different treatment options, alternatives, and also at work and how it might affect you at work. But I think more importantly as well, I'm going to try and talk about the bigger picture really of the menopause and actually what it means for your overall health and well-being in many other respects. So, but we'll come to all that. So, menopause is very widely discussed at the moment. It's a big topic. It's been brought to our attention by celebrities like Davina McCall. It's in the newspaper. It's on the Apple News app whenever you turn it on. It's everywhere. So it's a big topic at the moment, and quite rightly. More recently, there's been a lot in the news about sort of laws in the workplace and discrimination. We'll talk about that. So we'll start with the really basics of the menopause. It is diagnosed when you've had 12 months without any periods over the age of 45. If you don't have a uterus, because you've had a hysterectomy, for example, then it's with the symptoms of the menopause over the age of 45. The average age is about 51 years to go through the menopause. And there are different ways it can occur. So it can be naturally, and I'll talk about that in a minute, or it can be surgically, for example, having surgery to remove the ovaries, or it can be medical. And this includes having gone through things like chemotherapy, radiotherapy, or having injections to switch the ovaries off. So all these things can drop your estrogen levels and give you give you the menopausal symptoms as well. The perimenopause is slightly different, and that can occur much younger, so it can be in the 40s or even younger, and that's essentially when you have the symptoms of the menopause, but you're still having periods. They might not be very often, they might be quite irregular, they might be quite heavy, but you're still having occasional periods. So you haven't had that 12 months, but you're struggling with the hot sweats and symptoms similar to that. So that's the perimenopause. But then you've got early menopause, and that has a few implications for health, but that's when the menopause occurs under the age of 45. And then you've got premature ovarian insufficiency. So it used to be called premature ovarian failure. And that is when that's under the age of 40. So that can be in 20s, 30s, and even in teenage years. So that's when you start periods, and then they stop much earlier than 40 years old. And this is important that it's managed correctly because of the long-term implications of having no hormones as a young lady. And we'll touch on that later as well. So I think menopause should be considered more of a transition rather than a disease or something that we shouldn't talk about. It's important to talk about it, and the reason it's important is now that women are living longer. Many women are spending up to half or over half their life in the menopause. So it's important that we research it, we have good treatments, we understand the benefits of treatment and the risks. But also, really importantly, it's a really good opportunity to sort of look at health in general. So if you're going to spend half your life in the menopause, how can you have a healthy life? How can you be free of disease in that part of your life? And that's where I think, at the menopause, thinking about your diet, blood pressure, cholesterol, risk of diabetes, ensuring that you're getting the breast screening mammograms, ensuring you've had your cervical smear tests and they're up to date, and ultrasounds if necessary, and just making sure that you've reduced your risk of becoming unwell later in life. So why does it happen? These grey blobs are meant to represent the ovaries, and within the ovaries, these little darker blobs are the eggs. So at birth, so in the womb, you have the female fetus has millions of eggs, and then they're born and they lose quite a few of these eggs. And then as they grow up in their sort of younger years, they lose more eggs without having menstrual cycles. And then by puberty, they've got about 300,000-400,000 eggs in the ovaries. Now, when puberty starts, when the periods start, what happens in a period is a group of these eggs is recruited by the body. So the brain produces a hormone called FSH, and that's follicle stimulating hormone. And it asks the ovaries to make an egg, because the eggs make estrogen, and estrogen makes the body healthy and helps with the blood pressure, it helps with the skin, it helps with lots of things. So the body is saying to the ovaries, please, can you make an egg so we can have some estrogen? So the ovaries go, okay, well, here's a group of eggs. And of those eggs that are sort of recruited, as we call it, one of them becomes the dominant egg. And this egg makes lots of estrogen and it ovulates. Now, if that egg that's released doesn't fertilize and become a pregnancy, what happens is the period comes and then another cycle happens. So every time there is a period or a cycle, there is a group of eggs lost. So as the lady gets into their 40s, the majority of these eggs have been lost. Now, the first thing that happens is the perimenopause. So there's still eggs in the ovaries, but there might only be a few hundred or a few thousand. And the brain is it's sending this hormone FSH to the ovaries and saying, please give me an egg, I need some estrogen. And the ovaries are saying, well, I can't find one at the moment, but I will in a bit. So what happens is the periods become quite irregular because the body isn't giving up an egg. The ovaries aren't giving up an egg on a regular basis. So the perimenopause, you have these irregular periods. It's because the body is looking for this egg and it can't find it. But occasionally it will find an egg and that egg will develop, and the menopausal symptoms you might find get better, and you might find your hot flushes have gone for a few weeks. And then you have a period and the hot flushes come back because another egg hasn't followed on behind it. And that's the perimenopause. And then eventually the ovaries do run out of eggs, and the body's making so much of this FSH hormone, you can test it in the blood and it's high. But there's no eggs made, so there's no estrogen. And that's when the menopause happens. The periods stop and the symptoms persist. So what are the signs of low estrogen? The typical ones that I might see in clinic are things like hot flushes, anxiety, brain fog, changes to the hair, thinning, weight gain, and then other things like vaginal dryness, pain on intercourse, so discomfort having sex, and loss of sex drive. So they're the key ones, and we'll go through a few of those in more detail. So the hot flushes are often described as, well, they can start in the head and the face, or they can start in the toes and move up the body. They're often described in different ways, but in America they call them flashes. And night sweats are the same sort of the same sort of process as well. And it's due to this up and down of the FSH hormone and the impact that has in the brain and on the way your body maintains its temperature. And it's due to the body trying to find estrogen. It affects about 3/4 of women, and it can persist for 5 to 10 years. And on average, it lasts about 7 years. Other common symptoms is anxiety and low mood and the brain fog. And again, this is most likely due to the lack of estrogen. And it's often seen more in ladies who've struggled with things like PMS, so premenstrual syndrome, or PMDD, or ladies who've had things like postnatal depression. So ladies that are very sensitive to the changes in hormones in sort of in the menstrual cycle or after delivery of a baby. But it can affect women that have never had those problems as well. And you lose the estrogen, and that there's probably a few things, the reasons anxiety and depression occur, but the mixture of the night sweats, the anxiety, not sleeping very well, feeling very tired, that's certainly going to make symptoms worse. And then there's certainly an impact in the brain as well. So lack of estrogen, the brain is very sensitive to estrogen. And we know that if we do brain scans in a lady before and after the menopause, there's a big difference in the blood flow and the activity of the cells in the brain. So you do get this reduction in activity in the brain. You get laydowns of proteins, so abnormal sort of waste product that gets laid down in the brain. And that also, in addition to the brain fog and things, probably causes dementia and other long diseases as well that we'll come to. The other common complaint is vaginal symptoms. Now these include dryness, soreness, and it affects about half of women going through the menopause. And it even affects about 25% of those who are already on HRT, so sort of HRT through the skin or that they take by mouth, so what we call systemic HRT. And so even women on systemic HRT need some vaginal estrogen. And the reason for this is that the estrogen levels drop. The cells that line the vagina, which are normally very plump and very stretchy and produce mucus, they no longer do that. They become very rigid, very thin, very dry. And this actually changes things like the bacteria, and can cause thrush infections. And the bladder and the bladder neck and the urethra, so the tube that connects the bladder out, also has estrogen receptors in, so it's also sensitive to estrogen. And the loss of that increases urine infections as well. And so when the vagina is also dry and not stretchy, sex can be uncomfortable, can cause bleeding, can cause bruising, and can even at worst cause tears. So vaginal estrogens are very good. They're thought to be very safe, even in women with a history of breast cancer, for example. And they can also affect young women. So ladies that are breastfeeding, because of what breastfeeding does to the hormones, that can cause vaginal dryness, and those who are on progesterone contraceptive as well. The other common complaint is about libido and sex drive. Libido is very complicated. It's not as easy as testosterone, as much as we'd like it to be. Testosterone can be very good, but there's many factors that make up libido, and these include things like the vaginal dryness. So if it hurts to have sex and you bleed when you have sex, you're not really going to want to have sex. If you've gained weight or you're having hot sweats, you might not feel as attractive as you used to. So that might affect your libido. If you're having hot sweats and you're not sleeping and you're anxious and you've got a low mood, then that will affect your libido. The other thing is life events. So I quite often sort of ask my patients, is there anything else in the background going on with your life that you're struggling with? Because, for example, elderly parents who aren't very well, going to care homes, children who are leaving home, relationship problems, work problems, all these things as well impact the desire to have sex, or libido as we call it. And the other thing is, do you, as well as feeling attractive, are you attracted to your partner still? So there's lots of factors at play. And then obviously testosterone. Now, not every lady has a drop in their libido through the menopause, and that's because the body makes other types of testosterone, weaker testosterones from other places, such as the adrenal glands, which are little glands that sit on top of the kidneys. And for some women, that's okay, and that's called DHEA. But for other women, it's not quite enough. So we need to replace it. The other thing is bones in the menopause. So, about a fifth of bone strength is lost in the first 4 to 5 years after the menopause. The bones are built up through your adult life. That's why it's important to have diets with calcium and vitamin D and to do exercise. And then about a fifth of that strength is lost straight away. And that increases the risk of fractures, hip fractures, falling over, breaking your wrist. So this is something that we have to think about as well long term, and where HRT comes in. But the other things that you can do to keep your bones healthy is diets high in vitamin D, protein, fish oils like omega-3, fatty acids, weightlifting, well, not weightlifting, but weight-bearing exercises, not drinking alcohol excessively, and not smoking. So heart disease. So obviously we're going to talk about breast cancer, and we all worry about breast cancer with HRT, but actually more women die of heart disease. So that's heart attacks, and stroke as well. Even that's not heart disease, but more women die of heart attacks than they do breast cancer. So by having a healthy diet, a healthy weight, exercising, and starting HRT, and we'll talk about that, these are ways you can reduce that risk as well long term. And some people even use HRT to treat chest pain, so angina if you get chest pain when you're exercising, then HRT has been used for that. But you've got to be very careful. So I wouldn't, if you're over the age of 60 or you're 10 years since your menopause, don't just start HRT thinking it'll help, because actually it can make things worse. If you're thinking about something like this for either symptoms of the menopause or thinking you might be able to improve your health with it, I'd see a specialist about it. And also HRT as well can reduce risk of diabetes, and that's also a cause of heart disease. The other thing that's quite a common point of discussion in consultations is weight gain, and it does affect about half of women going through the menopause and the perimenopause. So even before the periods have stopped, women sort of in their 40s do start to gain weight because of this slow decline in estrogen levels. And by the menopause, on average, women have gained about 10 kilograms. But not only that, it tends to distribute itself differently around the body. So it tends to be more on the hips and the tummy, and also inside your tummy. So fatty deposits around the organs in your tummy. And it's that actually increases your risk of heart disease and things. So weight gain is another thing that we'll talk about. We've mentioned dementia. So Alzheimer's is a type of dementia. So it's sort of forgetting your name, forgetting where you live, forgetting to look after yourself. These are sort of signs of dementia. And it's twice as common in women. And it used to be said that, well, this is because women live longer. And dementia tends to be a disease of the older age. So if you live longer, more people in that group are going to get the disease. However, it's twice as common. So there was a big study in America that showed that women taking HRT probably had half the risk of developing dementia. So dementia, HRT is likely very protective. However, you probably have to start it very early on before the disease process begins, and you probably have to carry on the HRT long term. But then lots of people do. And as well as dementia, HRT is probably protective of Parkinson's. So we're talking about breast cancer now. So about 20 years ago, there was a study done in America that was released that said women taking estrogen and progesterone HRT had a 25% higher chance of breast cancer and heart attacks than those not taking HRT. So quite understandably, doctors stopped prescribing it, patients stopped taking it, and people stopped researching it. A few years later, there was a sort of a review of that study that said, hang on, actually, these patients aren't really representative of the people that normally take HRT. Some of these patients are in their 70s. The average age of the patient was in their 60s. So it doesn't really reflect those in their 50s and 40s who want to take HRT. So more trials have now been done. There was one in 2015, and then one published more recently in 2019 in The Lancet, which is a very big medical journal, that actually said, well, yes, there is a slight increased risk of breast cancer on HRT. And if you're taking it every day and it's estrogen progesterone, then there's probably one extra case for every 50 women over 20 years. So it's it is increased risk, but it's a very small increased risk. If you're taking sequential HRT, so that's when you take estrogen every day, but progesterone for only 2 weeks of the month, an extra case for every 70 women. So it's slightly lower risk, and that's because we believe that the risk of breast cancer probably comes from the progesterone element. And they also have been studies that have said, well, actually estrogen on its own, so for women that only need estrogen, probably had no increased risk of breast cancer, and maybe even lower risk And then also that vaginal estrogen also didn't carry risk. So a few years ago, we sort of said, right, okay, actually, HRT is okay. We should be prescribing it, or we can prescribe it. But the problem now has been for 20 years, doctors haven't really been educated about it. It's not really formed part of our training. And many doctors are still trying to catch up with these advances. And some doctors still believe it has a high risk of breast cancer, so still don't want to give it. So there's a lot of work to be done. Now, this is a really good infographic that I'll just run through. So for every 1,000 women, 23 women get breast cancer. If you take HRT, there's another 4 cases per 1,000 women. However, if you drink or smoke, if you drink more than 2 units of alcohol, you have a higher risk of getting breast cancer than if you take HRT. And if your BMI is greater than 30, you have a significantly higher chance of breast cancer than a lady taking HRT. So the reason this is a good infographic is it just puts it in perspective of what the risk is. And combined with self-checking, making sure you've got your mammograms, being on the right HRT, a HRT that carries a lower risk, for example, it's a risk that many women choose to accept for the benefit and the quality of life. We discussed HRT. There is another new drug called fezolinetant, which is it's called a neurokinin 3 receptor antagonist, but it came onto the market in January. I think it's about £45 a month. I don't think you can get it through the NHS at the moment, but it's possibly something that we can start using for hot flushes, which is not a hormone, so should be safe in breast cancer. So, this is something we can probably start prescribing now. This brings us on to other health benefits of HRT then. So we've mentioned a few things, dementia and bones. So if you start HRT within 10 years of going through the menopause, you have lower lifetime risks of fractures, diabetes, depending on the HRT. So E is estrogen, so estrogen only HRT. You have lower risk of bowel cancer if you take estrogen and progesterone. You have a lower risk of heart attacks. You have a lower risk of womb cancer, so endometrial is the lining of the womb, and that's if you take estrogen and progesterone. And you actually have an overall lower chance of dying if you take HRT. However, there are also increased risks of taking HRT. So there's probably less than 5 extra cases per 1,000 women of lung cancer, blood clots, if you take HRT through orally by mouth. Stroke, again, that's linked to blood clots if you take it by mouth. An inflamed gallbladder, and then potentially, as we talked about, breast cancer. So there are some small increased risks, but there are also some significant benefits. So HRT is something to seriously consider if you're in a situation where you're struggling with any symptoms. So now we need to think about, well, what sort of HRT am I going to use? It's not straightforward. It's almost a journey starting HRT. It comes down to, well, what symptoms are you trying to treat? What your preference is? Would you prefer to have it by mouth, on your skin, under the skin? Do you need a progesterone, so the bit that protects you from womb cancers? Are you at risk of blood clots or breast cancer? Do you have a family history of breast cancer? Do you carry a gene for breast cancer? So there's all these sort of factors. Do you want to have hormones, or do you want to try non-hormonal options? And the other thing is everyone responds differently. So there is no 2 patients who I would give the same treatment to who will get the same response. It's a case of starting something, seeing how you are, and altering it. If it's not quite working, we'll increase the dose, or we'll change the route, or we'll change the preparation. There's lots of things to think about. So it takes time to get it right. So progesterone then, yeah. So I've obviously scared you that it causes, this is the bit that increases the risk of breast cancer, but it's also the bit that reduces your chance of womb cancer. So if you have a womb and I gave you just estrogen, you might feel very well. However, the lining of your womb, which is used to thickening every month, will thicken with the estrogen, but it will never shed, because if I just give you estrogen all the time, you'll never have a period. The lining of the womb will just keep thickening. You'll have bleeds because the lining of the womb will get so thick it will just sort of shed, but it's not a real period. And if you take unopposed estrogen, so estrogen on its own for a long time, the cells that line the womb keep growing, keep growing, keep growing, and they can become precancerous and eventually, after several years, cancerous. So you have to have some sort of protection for the lining of the womb when you take estrogen. So the ways you can do that is you can have body identical things like Utrogestan, which is a progesterone that's very similar or is the same as the progesterone made in the body. Or you can have a little device that sits in the lining of the womb called a Mirena coil. And it's the little T-shaped device at the bottom of the screen in that picture. And it goes into the womb and it sits there and it secretes a high dose of progesterone in the lining of the womb. So anyone who's sensitive to progesterone tends to get less side effects from this because it's localized to the womb rather than going around the whole body. Or you can have it in patches, such as the ones on the bottom right. There are other, you can have it in tablets as well, combined with estrogen and things. The two ones that we believe are probably carry the lowest risk of breast cancer is the Utrogestan and the Mirena coil. So these are ones we tend to go with or think about. Progesterones also can cause side effects. So often the tricky bit with HRT is not always the symptom control, but it's actually the side effect control. So we might get someone's hot flushes managed, but then the lady's struggling with really bad sort of PMS type symptoms or heartburn or progesterone symptoms. So there are side effects, but they are manageable. And as I've said, you can have them in different ways. So we're talking more about the estrogen bit now. So the different ways to take the HRT. So we'll start with tablets. So when you're choosing the route to take, it's really up to you. There isn't. I try not to say, well, do this, do that, because it's sort of, well, how would you like to take your HRT every day? Because you're the one that's going to be taking it, not me. So tablets are, some people like them because they're easy. You take one a day and that's it. Some tablets, such as Tibolone, is an entirely synthetic estrogen progesterone, but it also has a bit of activity, testosterone activity, so it helps with libido. So some people like that. It contains the estrogen and the progesterone, the tablet, so you don't need to worry about coils or extra tablets. Yeah, so it's quite lots of people like it. However, there's a small increased risk of blood clots taking tablet HRT, and that's because the estrogen, which you take through your mouth, when it gets absorbed in the body, goes through the liver, and that causes this increased risk of blood clots. So for some people, if they have any risks of blood clots, we tend to suggest going through a different route. So examples include things like Femiston, LS, Duet, Cliofem, Cliovance, and Tibolone that you may have heard of or may even have tried. Other options is HRT through the skin. So the benefits of this is there's no risk of blood clots. The patches are just twice a week, so you don't have to remember anything every day. You just put it on a Monday and a Thursday, for example. The patches go on your arms, your legs, your buttocks, your tummy, anywhere really, just avoiding the breasts. And as I say, you just change them twice a week. And they can be good for women who are both menopausal and perimenopausal as well. Other types through the skin, like the gel, it's really easy to adjust the dose. So you can go up to 1 pump of gel, 2 pumps, 3 pumps. You can split dose, so you can have gel in the morning and the evening if you find your hot sweats are worse at night. So there's lots of things you can do with the gels and sprays that you can't do with other preparations. Other things like implants, so these are sort of increasingly popular. It's a little pellet, probably it's about the size of a grain of rice, to be honest, and it just goes under the skin in the buttock or in the lower tummy, and it sits there for 6 months, and it releases hormone in a sort of consistent level. and you just have to come every 6 months to have that topped up or a new one put in. Very easy to do. You can forget about it. An excellent absorption as well for anyone who's struggling to absorb through the skin or by mouth. So those sort of people that don't get symptom relief or whose estrogen levels in their blood stay very low despite having it sort of the gel or the patches, quite often by putting it under the skin, we very quickly get the estrogen levels up and get good symptom relief. So they're increasingly popular. And also the patches can include a progesterone. Downside to them is, whilst you technically should be able to swim and shower and things, they can fall off, especially if you find you're sweating quite a lot. And also some people get reactions. So the Everel patches, quite a few people get reactions to. There are other patches like Estradot that you can try if you have a reaction to it, but sometimes they're not good either. The gels can be quite messy. Some people don't like having to get showered, then put it on, walk around for 20 minutes undressed whilst it dries. Some people just don't like that. And stock issues, as I mentioned. So yeah, examples include things like Everel, Estrogel, Fem7 estrogen, and then estrogen testosterone implants. And yes, you can also get testosterone implants as well. Then you've got vaginal HRT. So we talked about the vaginal dryness, soreness, discomfort having sex, urine infections, recurrent thrush infections. So the benefits of vaginal estrogen is it improves vaginal sensation, so sexual function, helps with lubrication, and then, as I said, sort of reduces urine infection, stops thrush. And also, if you've got a minor prolapse, if you feel like there's something rubbing a bit of estrogen is often all you need to help you avoid surgery, having to have prolapse surgery. So that's a good use of it. Sex is more comfortable, and then obviously it improves libido. The downside to it is, whilst you can get tablets, you can get creams. The creams are quite messy, but actually some people find that quite soothing. They can make the skin sore, so the introducers to put the tablets in sometimes catch. That can sort of be, you can sort of get around that if you use some sort of lubricant jelly to put the applicator in. And then they're fiddly. So if you're sort of struggle with reaching down below, if you've got any sort of reduced mobility or function in your arms, that you can't really do it very easily unless you've got a relative, a partner or a district nurse to do it for you, for example. And examples include your sort of Avestin cream, orthogynes creams, Vagifem tablets. There is a vaginal ring, and then you've got actually a tablet ospemifene, which is it's an estrogen. It's not an estrogen, but it's an estrogen receptor modulator. So it acts on the vaginal skin, even though it's a tablet you take by mouth. And then you've got non-hormonal things like lubricants, and then DHEA. Now, DHEA is not something I prescribe really, or haven't prescribed it. There isn't really any evidence it's better than a placebo. So the studies haven't really shown that DHEA vaginally helps really with sexual function. It's also quite expensive. The next question is really, how do you take HRT? So there are two different things. So if you are still having periods, so you're perimenopausal, so you're still having occasional periods, but you're struggling with symptoms of the menopause, then you need to still have a bleed, because if you have a constant estrogen and progesterone every day, what happens is you will occasionally make an egg and make estrogen, and that will cause the lining of the womb to thicken, and you'll get erratic bleeding. So if you're still having periods, you still need to have a bleed, unfortunately. The only way around it is if you have something called a Mirena coil to sit in the lining of the womb, and then you don't need it cyclically. But if you're taking patches or tablets, it has to be cyclic or sequential is the other thing it's called. So the way to do that is you take estrogen every day, but you only have the progesterone for sort of 14 days a month as a sequential therapy. And you take the progesterone, and then when you stop the progesterone, you'll have a bleed, and then you just carry on and do the same thing again 14 days later. When do you change to estrogen progesterone every day? It's a bit tricky. I usually just go around the age of 51 and go change it to continuous. And then if there's bleeding problems, sometimes switch back to cyclical for another year or so and then try again. And the reason for that is the continuous HRT, when you take estrogen progesterone every day, if you're postmenopausal, so if you no longer have periods, there is a lower risk of endometrial cancer if you do that. So that's the reason to change from sequential to cyclical. But knowing when to do it isn't always that straightforward. We replace estrogen and progesterone, but so why don't we replace testosterone? It's a key hormone made by the ovaries. I think the reason we don't jump straight in to replace testosterone is for many women, they don't need it. There is this weaker hormone, DHEA, made by the adrenal glands, that for many women is enough for libido. And then also, many women get benefit from estrogen for their libido. So they start estrogen HRT, and then three months later, they feel better, their weight's coming down, they're not as sweaty. And actually, they say, actually, my libido is really good now, I don't need anything else. So we tend not to jump in with testosterone straight away. And the other reason for that is there are theoretically some risks with testosterone. If the levels creep outside of the female levels, you can get sort of beard hair, you can get an irreversible deepening of the voice, and you can get enlargement of the clitoris. So this is a sort of what people think of as a male hormone. So it has these sort of male changes. So whilst this is not common, and by keeping the doses at a sort of a sensible level and checking the hormone levels every few months, this doesn't tend to happen. But this is the reason we don't jump straight into it. And it's also not licensed in women in the UK. There are different ways to take it as well. So there's testosterone sachets where you take a sort of pea-sized amount every day. There's Tostran gel, which is a bit stronger, so you use that every other day. There's an Australian one called Androfem, which again, it's just a topical cream. And then you've got the implants as well, the testosterone implants, which you can see a bit like grains of rice, and they just go under the skin every 6 months. And it's supposedly, it improves libido. Most people say it does improve libido, and maybe even things like drive and energy and sort of brain fog. But the evidence for those things is not quite as strong. But certainly people say it does benefit those as well. So as a combination with estrogen, progesterone, HRT, or just estrogen, it can be really effective for improving quality of life. There are a few groups of people that are unable to take hormones, and the key one really is those that have had a personal history of breast cancer. And that's even if it's estrogen receptor negative. And the reason for that is about 10 to 15% of women with an estrogen receptor negative tumour potentially have an estrogen positive tumour somewhere in the breast tissue. So personally, I don't base my decision to start HRT on whether the tumour was estrogen receptor negative or positive. And I often write to the oncologists, the cancer doctors, and I seek their advice, and the response is always the same. I wouldn't recommend them taking it. There are exceptions. Things like vaginal estrogens are generally accepted as being okay if you've had a personal history of breast cancer because of the very, very small dose of estrogen that gets into the body. So for these groups of people, and for those that just want to avoid hormones, when are the other options an option? So if you've got very mild symptoms and they're very short lasting and not that troublesome, then simple things like lifestyle, so exercising, changing your diet, acupuncture, losing weight, can have a real impact on your mood, your anxiety, and your quality of life. Things like food, so red clover, soy, these have plant estrogens in that can help. But beware, in breast cancer, you should really avoid these as well because they're still estrogens. Then you've got the herbal options, Holland and Barrett, like ginkgo biloba, ginseng, black cohosh, St. John's wort. And there is some evidence for some of these of a benefit, certainly for mild symptoms. If you're taking St. John's wort, just be very careful because it interacts with a lot of medication. So check with your doctor before you start taking St. John's wort. And then you've got non-hormonal. So for those that really are struggling with their symptoms, such as those with breast cancer who can't have HRT, there are things like clonidine, which is a blood pressure tablet that can help with hot flushes. There are antidepressants, such as sort of SSRIs that you might see for anxiety or depression, that can help with some mild symptoms, or neuromodulators, things like gabapentin, pregabalin, that can help. However, you need quite big doses, and there can be quite reasonable side effects to some of these medications as well. But there are options out there, and you have to accept that the side effects, especially for the herbal options, there is a cost, and for many it will delay getting to receive HRT, and then doesn't always work. So, but there are options to discuss with your healthcare professional. The other thing that often comes up in clinic that I talk about, and more often than not, unfortunately, it's sort of seeing patients who've been on it and had problems and then have come to see me, is bioidentical. So there are lots of clinics, especially in London and online, who are very pro bioidentical hormones or HRT. The thing to remember about these is they're often not given by prescribers. They're often sort of specialist pharmacies who make them up. They're not regulated in the same way drugs are in the UK by the Medicines Health Regulation Authority. They're essentially unregulated copies of hormones. You don't know what you're getting. You don't know what the dose is in the tube you've bought. You don't know what the purity is. And you could have 2 tubes of the same thing with a completely different doses. Now, for a menopausal woman, you probably need an estrogen of around 600 to 800. I've had patients come to me with estrogens over 2000 who have palpitations, they can feel their heartbeat, they feel ill, and it's because of these preparations. So just be very careful with bioidentical, and it's not evidence-based for safety or benefit. And the other probably really important thing is it really protecting the womb? So often there's sort of topical progesterone, bioidentical progesterones that you rub onto the skin and things. We just don't know it's protecting the lining of the womb. So if you're taking high dose estrogen that's giving you huge estrogen levels, are you developing precancers or cancers in the long term in the lining of the womb? So the British Menopause Society's stance on this is to sort of avoid, really. It just doesn't have the evidence of safety or benefit. So weight gain. Weight definitely increases in the perimenopause, menopause, as we've discussed. And this is a really common thing as well to discuss in clinic. And it does come down to sort of 3 basic things. The first thing is are your menopause symptoms controlled? Because if you're not sleeping, you're anxious, you're having hot sweats, you're not going to be able to exercise. You're going to be probably eating poor diet. Your sleep will be poor. You won't have energy. So that's what, let's control your symptoms if there are any. The next thing is calories in. The best thing I would do, and what I would want my patients to do, is start with a food diary. For 3 or 4 days, write down everything you eat, when you eat it, and everything you drink and when you drink it, and every time you move. So if you have a sedentary job, for example, and you work at home, if I'm working at home, I'd try and get out for a walk or go for a swim or something, just because I know I've not moved all day. So keep a diary, and then take it to your GP, take it to your menopause doctor or dietitian, and sit down with them and say, look, where am I going wrong? Then think about your meals. So there should be about, if you have a plate, there should be about 1/4 of your plate should be protein, and that can be plant protein or fish or meat, and then 1/4 should be carbohydrate, but low GI carbohydrates. So carbohydrates that increase your blood sugar slowly. So not things like chips or potato or white bread, but more things like brown pasta, brown bread, complex carbohydrates like porridge. These things are really good for giving you a nice steady sugar level in your blood, and that then means you don't lay fat down. And then half of your meal should be fruit and vegetables as well. So filling up on things that are protein, fruit, vegetables, rather than the carbohydrates. And then reducing your portions. Now, this is not something you can do quickly. When you cut down your food the amount you eat, you will be starving for probably 2 weeks. But then at 2 weeks, you won't be starving anymore. So you have to bear with it and do it slowly. So slowly reduce your portions, cut down on things like alcohol that are just empty calories. You know, a glass of wine is like eating a donut, and you wouldn't sit there, well, most people wouldn't sit there and eat 3 donuts, but you might have 3 glasses of wine. So think about that as well. And then there's calories out as well. So exercise is really important for your heart and your well-being and your mental health. But if you go for a run and do 10 kilometers, you might burn 500 calories, but then you can get home and have a muffin and then you've eaten 500 calories. So exercise isn't really the way to lose weight. It's a way to stay fit and healthy and change the body composition and build muscle and lose fat and feel more attractive and have and better mental health. So that's sort of where calories out comes in. So ideally, gym a couple of times a week, go for a brisk walk, for over 150 minutes a week, go for a swim a few times a week, that sort of thing. And add in vitamin D to your diet as well. Most people need a standard dose vitamin D. And the other key thing really is get tailored advice. So I'm not advising you here, but I'm just saying these are the things to think about. Talk to your GP, talk to a dietitian, talk to me, a menopause doctor, anybody. And then coming onto the market now, you've got Ozempic, Wegovy injections. I think this is probably going to be coming into women's health more, for certainly fertility as well. I'm seeing more and more papers and things talking about, should we be giving fertility patients these injections as well. Very quickly, migraines. They're usually due to stopping and starting progesterone. So there are ways to reduce migraines, like a Mirena coil, changing the progesterone, changing the doses and things. Premature ovarian insufficiency. The reason this is important is if your period stopped at the age of 30 and you had 20 years of no estrogen, when you need estrogen, you'll have weakened bones, high risk of dementia, heart disease, and so on. So it's really important for health to treat it. And symptom-wise, obviously, symptom control, libido, sex drive, vaginal symptoms, and so on. So this is something that I see in clinic quite a lot as well, and it's really important to treat. The treatment options are the estrogen progesterone contraceptive pill, or HRT. That's just giving those hormones back. Now, the also important thing to remember here is there isn't the breast cancer risk with HRT in this group, because you're just replacing what should be there. So we don't generally worry about that. Then you've got vaginal estrogens, exercise, diet, and then also counselling around things like fertility. Can be a big, obviously that can be quite devastating for some women. But there are options out there, and that's another talk altogether. Contraception. So HRT is not a contraception. So if you go on it in your 40s, you still need something. And if you have premature ovarian insufficiency and you're on HRT, it's also not a contraceptive, and you can conceive on that. So about sort of 1 to 2% of women with premature insufficiency can still conceive. So bear that in mind. So if you're under 50 and it's been more than 2 years since your last menstrual period, you can stop your contraception according to the Faculty for Sexual and Reproductive Health. If you're over 50, then it only has to be 1 year. And if you're over 55, then even if you're having period, you can probably stop contraception. The Equality Act 2010 protects workers from discrimination, and that includes menopause symptoms. So if your menopause symptoms are impacting your ability to work, then it is technically a disability, and your workplace has a legal right to make reasonable adjustments. And if they don't, then they're breaking the law. So what sort of things can they do? Support groups, flexible working, giving you a fan, changing what you need to wear, introducing policies. So there's lots they can do, and the Equality and Human Rights Commission have lots more information on their website as well. And it affects a lot of women. I think more than we think. So there's a survey done did suggest 90% of women. I've seen between 75 and 90% of women say that their symptoms impact their work. So do speak out if you're struggling. A few takeaway points. If you're struggling, even if you're in your 40s, get guidance from your GP or a menopause specialist, because there are benefits to starting HRT treatment, as we've discussed, and benefits that probably that you probably benefit more from if you start HRT early on. Don't struggle on. You should talk about it. You should discuss it with friends, family members. It shouldn't be taboo. Start with estrogen. Yep. So in terms of libido, start with estrogen and then go on to the testosterone if you need it, is my advice. Think about which symptoms in particular you're struggling with, and also what type of HRT you might want when you see a doctor or specialist. And then, I think the other big message really from today is see it as an opportunity to improve your health for the rest of your life. So it's not just about treating your hot flushes. It's about optimizing your health so that the next potentially half of your life is in good health rather than in with disease. So consider all the things we mentioned earlier, like your blood pressure, diabetes risk, and even lots of people have sort of annual health checks and things just to check. And because if you have high cholesterol, you can start medication. If your blood pressure is high, you can start medication, change your diet and lifestyle, and reduce your risk of disease. All right. Thank you very much for listening. If you have any questions or you want to contact me or the hospital, then you can either contact us through the hospital, Park Hospital, or Thornbury Hospital in Sheffield. Alternatively, my secretary, Mandy, but her details are there on the bottom of the screen. But thank you very much.